But thank you all for coming. For those who may not know me, my name is Lewis Payton. I'm a senior lecturer at the University of York, based in the medical school, and I am the deputy theme lead for mental health in ARC 2. So I'm supporting Professor Simon Gilbody, who is once again leading our mental health work here in York. And it's a pleasure to be here talking about our plans for the next few years. So while our planned work spans a wide range of topics, I think the common thread underpinning everything we do is a drive to reduce inequalities in access and treatment for mental health. So that's hence the title, which we've tried to, it's a very grand title, but we tried to sum up what we're doing is from evidence to equity. So obviously, mental health is one of the leading drivers of health inequality. So we want to try to better understand potential barriers and evaluate novel interventions. So today we are hoping this is going to be quite a bit of a kind of an open conversation, because we want to talk through some of the things that we're working on, and it'd be great to get your thoughts and opinions on those plans as we kind of continuously develop them for the rest of the ARC too. So just for a little bit of background for those who don't know the setup as we've moved into this new phase of the ARC, the mental health theme in the ARC is once again a collaboration between the universities of York and Sheffield. So the Sheffield team is led by the brilliant Dr. Emily Wood, who many of you may know, and I think is somewhere on this call. Our colleagues in Sheffield are, please correct me if I'm wrong, Emily, focusing on access to care and the mental health workforce. But what we've done with these lunch and learn seminars is kind of split them up. So York are going to kind of lead one, and then Sheffield are going to lead the next one to try and give the space for our individual pieces of work. And so Sheffield are going to be the focus of the next lunch and learn, I believe. In York, our work is going to focus on kind of two work streams. So children and young people and the physical health of people with severe mental illness. But we're also going to be working very closely with some of the other ARC 2 themes. So in particular, data analytics, prevention and early intervention for children and families, and also the health economics theme as well. And we're going to touch on various aspects of these kind of cross-theme working today. It's great, as you will notice from the beginning slide, there's three names on there. It's great to be joined by our workstream leads here in York. So Dr. Ruth Wadman joins us, and Ruth is an associate professor in children and young people's mental health at the University of Bradford. And Ruth is leading our CYP work, and also joined by Dr. Claire Carswell. So Claire is a research fellow and NIHR advanced fellow here in York, and Claire is leading our SMI workstream. So it'll be a bit of backwards and forwards between the three of us. Hopefully it's nice and smooth. Apologies in advance if it isn't. But I'm now going to hand over to Ruth to kick things off with our work on CYP.
Thanks, Lewis. So I am leading the Children and Young People's Mental Health work stream. This is a piece of work that was only an area of focus in the most recent ARC 1.5. So this is a new area of research for the ARC. So next slide, please. Thanks. So thinking about highlights from the last 18 months working with ARC 1.5. So we've actually achieved quite a lot. We've built capacity for eating disorders research. So we've brought in expertise, national experts in eating disorders in young people. And we had a really nice collaboration with Bradford District Care Trust Eating Disorders Services. And that work was really shaped by conversations with schools and school staff who were actually quite anxious about the thought of doing research into eating disorders in schools. So we've actually done some qualitative interviews with parents and teachers and young people themselves to shape what doing good research around eating disorders looks like in schools. So I think that's a really practical piece of work that can shape eating disorders research moving forward. We also did some development work, including PPIE work with groups of young people, to develop new methods for social media research. And this also involved co-designing a social media use intervention. So that's fed into the larger in real life trial, which many of you may have heard of, which is a trial of this social media restriction app in schools in Bradford. We were really pleased to secure 2 funded studentships as part of the YHARC. So the first is looking at adverse childhood experiences and how that is associated with subsequent adolescent mental health outcomes. And the student working on that, Natalie Lamb, is actually the first person to look longitudinally across the Born in Bradford cohort through to the Age of Wonder cohort. So that's very exciting. And a second studentship with Eliza Shotton is focusing on the prevalence and correlates of eating disorders in young people in Bradford. So doing some really interesting work about ethnic minority groups and what rates of eating disorders look like for those young people. We've done some nice pieces of policy engagement work. So we've had 2 very successful evidence into policy workshops attended by senior decision makers and NHS, local council, voluntary sector. So those are really, really great events and supported lots of conversations around bridging that gap between evidence and policy. And we were also able to lead on the Child of the North mental health report, which made recommendations to the government about addressing inequalities that we see in the North around children and young people's mental health. PPIE and co-production has been a key part of everything we've been doing. So I've just put a couple of examples here. So we worked with a group of young people to co-design a systematic review project. So this was on the knowledge, attitudes and behaviours of first responders following an episode of self-harm. So that's been shared widely now with policymakers such as in education, local authority and schools. So we'll likely have impact in terms of shaping what safeguarding and self-harm policies look like in schools, for example. And we also had some really productive workshops around eating disorders in ethnic minority groups, which has fed directly into that PhD studentship that I mentioned earlier. And we've also been thinking quite a lot about research inclusion, working with young people to really think about how we need to do our research so that it is being inclusive for all young people. And finally, we have created a curated Age of Wonder data set. So this is for postgraduate students to do their projects on. Lewis is going to touch on that later. So yeah, next slide, please. We're really happy to support the Promoting Positive Adolescent Mental Health, the PAM intervention. So this is a cluster randomised RCT that's currently underway in Bradford secondary schools. The PAM is a multi-level school-based intervention, so it has some whole school approaches. So that's things like having a committee of young people and staff in the schools, assemblies, having a wall magazine and a speak out box. It involves peer group work, but also individual referrals and signposting for further support. So this is an intervention that was based on the WHO's Health Promoting Schools framework. We took an intervention that was trialled in India and with our groups of young people adapted it to be suitable for Bradford secondary schools. So the activities are intended to generate awareness, to develop social, emotional, and problem-solving skills, and to generally improve relationships between students and between students and staff within the school. And the aim is to create a more positive school climate. So our rationale is that by creating a positive school climate, that will support young people's mental health in schools. And a positive school climate is very much around valuing student participation in school decision making. So that's things like, having a say in what school policies look like. It's about fostering a sense of belonging to the school and encouraging supportive relationships within the school. So this isn't a mental health intervention per se, but mental health is one of the topics that the group work and whole school approaches will be covering. Other topics include wellbeing and environment, relationships, so that includes bullying and racism, and school life, which is things like exam pressures, but also thinking about future careers and opportunities. And this is an intervention that's delivered by wellbeing mentors, and they are non-clinical community support workers who are in the school for a couple of days a week. And their remit is really to be visible in student areas, to be very much seen as being on the side of the students, and to be promoting student voice. So this has been a challenging intervention to implement in schools, but it's going well, and early days, but it is being well received by secondary schools. Okay, thank you. We, as I mentioned, do work very closely with young people, several groups of young people in Bradford. And, we're always thinking about dissemination and outputs and how to make them appropriate to different audiences, including young people. So we co-developed a animation explaining what systematic reviews are, for example. And we've had podcasts and other outputs. So I just wanted to share that. Okay, Lewis. So what next? Well, our question is, how can we reduce the burden of mental health problems in children and young people? And we have a two-pronged approach to trying to get the answers. Next slide, please, Lewis. So our first approach is data-driven. So we want to bring together data from the Born in Bradford cohort, but also other national cohorts across England. So, for example, Be Well is in Manchester, Oxwell is in Oxford and other places in England. And we want to develop collaborations across regions and to do analytic projects that will inform better and new ways to support young people's mental health through policy and prevention. So some of the data analytic projects that we have in the pipeline will look at mental health service use and engagement, including inequalities in access. We're also interested in intervention effectiveness and how cohort data can be used to evaluate interventions, but also with very much a focus on prevention and early intervention. We want to look at risk factors and targets for prevention. Some of these projects will be shaped directly by PPIE work with young people. So, for example, loneliness as a risk factor for mental health difficulties, but also understanding differences between ethnic groups in terms of risk factors. And this is a cross-YHARC project alongside the data analytics theme. Thanks, Lewis.
Oh, I think it's me. Sorry, it's not been quite smooth. My next slide, as I'd hoped, I will try. So thanks for it. So I think a really nice example of some of the work we're doing in CYP space, kind of with the co-prediction embedded, is our work on loneliness. So this is being led by one of our excellent early career researchers, Dr. James Myers, and adolescent loneliness is an escalating concern. And we know it's linked to a wide range of poor mental health outcomes, but also physical health outcomes as well. And we also know that loneliness is it's not distributed equally. So we know that there's quite a strong association with socioeconomic status or deprivation, and this is a phenomenon which is known as the social gradient. And so I suppose what we're trying to do in this study is understand actually what specific behaviors or exposures might disrupt that link. Um, so how can we kind of interrupt that kind of association between deprivation and loneliness and mental health in a way that might pave the way for potential early interventions? So to explore this, we are using one of these data sets that we've talked about, born in Bradford, Age of Wonder cohort. And so this is, the ongoing longitudinal study in Bradford, and co-production with young people is embedded throughout this, through this entire project. So we've already held a workshop to understand actually what impacts loneliness for today's young people. So it's a very different landscape, even compared to the relatively recent past, when you had smartphones, social media, the impact of the pandemic, and all that kind of social disruption that came out of that. And that lived experience is going to feed directly into our statistical analyses. So as Ruth said, we're working very closely with the data analytics team to kind of apply advanced statistical modeling to these data sets. So we want to actually map how these external factors that the young people identify moderate or interrupt the social gradient of loneliness, and then hopefully that kind of can help us identify potential ways to intervene in that. So again, we've got further co-production planned at the end to help kind of shape what that might look like. And I think back to Ruth. Talking of interventions, back to Ruth.
Thanks, Lewis. So our first approach is data analytics, and our second approach is interventions. So we want to examine the effectiveness of innovative approaches to mental health intervention, with a particular focus on early intervention, on psychological and school and community-based interventions. So we're moving beyond the clinic, and also with digital tools and their potential as well. So at the moment, we are looking for candidate interventions that are potentially scalable in school and community settings, including sort of digital settings, that we can implement and evaluate through the YHARC. And candidate interventions may be around social anxiety, loneliness, which we've just heard about, but also things like being well and staying safe online. We're also thinking about target groups for interventions, because we know that access to care is not equal across different groups of young people. So we want to think about ethnically diverse settings and what interventions may be appropriate to those settings, and also settings living with higher levels of deprivation. But we also want to think about children and young people with neurodevelopmental conditions. So that's things like autism and ADHD. They are at increased risk of developing mental health conditions. So we want to think about how we can try and protect those young people's mental health. So we don't know exactly what these interventions will be. We want to find things that are being developed in different parts of the NIHR infrastructure. So, for example, in the biomedical research centres that have, some evidence base and that would be appropriate to be scaled up in the Yorkshire and Humber region. And through that work, which will involve almost certainly adaptations to the interventions and the way that they're implemented, we want to deliver an adaptable framework, or frameworks for that matter, that other ARC regions can use to help them implement these school and community-based interventions in their locality, whilst taking account of any local challenges and inequalities and how that might shape the intervention. So that's a much longer term goal as part of the ARC. And that is a piece of work that we'll be doing in collaboration with schools and local authorities and the voluntary sector, to help us develop that framework into something that will be useful. So this work around interventions is a cross-ARC collaboration with the prevention and early intervention theme. So I think that is my whistle-stop tour of children and young people's mental health research planned in ARC 2.0. So I'm going to hand over now back to Lewis.
Yeah, brilliant. Thank you, Ruth. Yes, it's back to me for a bit. So I'm going to talk a bit, actually slightly different to what I promised at the beginning, is actually just a bit more of a deep dive into our data science work embedded in ARC 2.0. So we're embedding data science across both of our work streams. I'm going to focus on children and young people, particularly in this talk, because that work's slightly more advanced at this particular moment in time. So I think a really crucial thing is that making better use of data and technology, so particularly AI, is a core part of the NHS 10-year plan, in particular the 5 big technological bets. And we're really keen to be at the forefront of that, seeing how these can be applied to both children and young people, but also people living with severe mental illness as well. So we're working really closely with our colleagues in the cross-cutting data analytics and AI theme, led by Professor Mark Williams and Jake Abbas. And so we're really keen to use data and fancy methods to increase our understanding of different conditions and evaluate novel interventions. I'm going to talk about a couple of examples that we've got ongoing at the moment. And also we're really keen to build data science capacity across the region and beyond. That's a really kind of key goal of ours over the next 5 years. And to build capacity, one of our biggest vehicles is the Age of Wonder curated data set that Ruth briefly mentioned earlier. So this is, well, if you've seen me talk at any ARC events, you would have heard about this, because this is what I've been banging on about for quite a while now, but it's live now, which is really exciting. So this is a simplified version of the Age of Wonder cohort study that is ready for use. So we've kind of built this in a way that takes some of the data processing out of it that we know can be essentially a barrier to students who maybe aren't quite so experienced working with kind of cohort data. And thank you to the BIB exec team for making this available to postgraduate taught students across the region. And it's been designed specifically for those postgraduate taught students who are kind of keen to apply these cutting edge methods to mental health research. So the data set contains information on approximately 7,500 young people from Bradford. And the Age of Wonder focuses on really kind of key strategic areas. So common mental disorders, eating disorders, early psychosis, these kind of key strategic areas. And like I said, it's really exciting because it's actually now live. It's being used as we speak. So we're supporting multiple projects already this year at universities right across the Yorkshire and Humber region. And we're always keen to expand outwards. So please get in touch if you've got postgraduate taught students in mind who will be keen to use this. And it's going to continue to be developed and expanded across the life of ARC 2.0. So we're kind of hoping that we're going to be able to support tens and tens of students, hopefully increasing capacity, increasing the amount of data science mental health research that's done across the region. So it's really, really exciting. In terms of some of the kind of research projects that we've got ongoing, we're going to highlight a couple, which I think are really, really exciting. So one of the things we're going to do is use data and advanced methods to evaluate, potentially exciting interventions, particularly digital interventions. So obviously there's quite a lot of focus on kind of digital apps, CBT or other types of therapy delivered through an app, given their scalability and the way they can be kind of, quite easy to implement in some regards. And so we've got a couple of examples which we're working on, but one which is just about to launch is led by Dr. Lucy Tyndall here at the University of York, and we're working with North Point Wellbeing in West Yorkshire to evaluate digital CBT apps in young people. So these apps have been they've been conditionally recommended for depression and anxiety in adolescents, but with a call for additional evidence. And we're delighted to be able to be generating that. So we've just about to start an RPB funded 12-month study where we are going to be collecting kind of prospective data and then provide kind of gold standard evidence, so kind of almost trial standard evidence with these advanced methods. I'm very happy to go into these in any detail if anyone wants to. I know probably I might be the only person on here who gets very excited by these methods, but it's very exciting methodology. But the crucial thing is it gives kind of nice approved evidence outside of randomized trials. So it's a much more scalable, much quicker way of generating kind of efficacy evidence for these apps for depression and anxiety. And what's really exciting is this evidence will be actually submitted directly to NICE as part of their kind of ongoing evaluation of these apps. So it's a really nice route to kind of demonstrating the impact that these methods can have. And of course, like all of our CYP work, there's co-production with young people embedded throughout this as well in terms of what kind of actually constitutes a completion of treatment, for example, is one question we're co-designing with the young people, and also how we disseminate the findings and all these kind of other aspects. So that's kind of really nice, exciting opportunity that we're just about to start. And then finally, and it's slightly different because it's not specifically children and young people, but there's an awful lot of focus on children and young people, is we are leading work to understand one of the most pressing challenges facing kind of mental health services and mental health providers and mental health researchers, which is the impact of online environments, digital environments, or online environments. So obviously, I'm sure everyone in the room is aware that there's been huge press coverage, legal cases, lots of commentary, all these other things about potential digital harms. And obviously legislation such as the Online Safety Act and the government's recent announcement of social media bans have kind of begun to be implemented. The problem from a research perspective in this space is that the existing evidence is actually quite limited because it has primarily relied on self-reported data. So technology companies haven't been willing to share their data for research. So we've had it's difficult to untangle what constitutes unhealthy online behaviors, all these other aspects of things. What's really exciting is the Smart Data Donation Service, which is based in the University of York, actually provides kind of a step change in how we research online engagement. And what it is, users actually donate their actual online activity records. So what apps they've downloaded, when they open the apps, when they close the apps, what they watch online, and they donate those data for research. And donors are also actually answering mental health questionnaires alongside these data donations. And so we're working really closely with the Smart Data Donation Service to apply some really kind of advanced models to understand the link between what people do online and their psychological well-being. So it's kind of really exciting stuff that we're kind of going to be doing over the next few years. And then ultimately what we want to do is actually use those findings to build targeted interventions that actually can hopefully improve digital well-being. So this works in its really early stages. There's not kind of too much detail we can give at this particular moment in time. It's still kind of getting off the ground. But we will be talking about it a lot over the next few years. So it's really exciting stuff. And just wanted to kind of put that out there. That's something that we're also working on. That is it, I think, if I can remember our slides. For me, yes. So I am now going to hand over to Dr. Claire Carswell.
Thank you, Lewis. Hi, everyone. So, as you've heard, I'm Dr. Claire Carswell. I am an NIHR Advanced Research Fellow based at York, and I am brand new to the YHARC, similar to Lewis. Lewis is fairly new as well. And I've joined to help lead to lead the severe mental illness work stream. And while I wasn't involved in ARC 1.0 or ARC 1.5, I'm going to go through some of the ARC aligned programs to give you an idea of the context in which we're kind of going forward with ARC 2.0. So you'll probably have heard about several of these projects that I'm going to talk about. Scimitar or Scimitar Plus was led by Professor Simon Gilbody at the University of York and was looking at smoking cessation for people with severe mental illness. And it was actually the largest smoking cessation trial for people with severe mental illness. And it was able to demonstrate effectiveness, showing that twice as many people allocated to the Scimitar intervention were abstinent from smoking at 6 months compared to usual care, which is a great outcome and actually resulted in the Scimitar Plus program being used as the national template for services and service specification for people with severe mental illness at the National Centre for Smoking Cessation and Training. Now, as you know, the landscape of sort of tobacco use and nicotine use is changing, which is something that I know everyone working on Scimitar and Scimitar Plus is very aware of. So that's something that we're mindful of going forward. And then there were projects in the initial ARCs looking at bridging the digital divide. Because people who have severe mental illness, some of them struggle with digital literacy and maybe do not have the same access to digital services as people without severe mental illness. And with the shift of healthcare services going digital instead of face to face, especially after the pandemic, there is this push to really improve accessibility of digital services for people with severe mental illness so that we don't further widen the mortality gap by making services even less accessible. So there were projects such as Spider ED, with which Ruth Wadman on the call led, which was a PPIE focused project looking at a standardized assessment of digital skills among people with severe mental illness in the UK, and then developing creative resources to actually support people with severe mental illness to become more confident and improve their digital literacy. And then there was Dragon, which was a small project that was evaluating how best to support people with severe mental illness to complete the Learn My Way digital skills courses. And Ruth was telling me that someone on that project actually was able to access gainful employment as a result of the digital skills that they learned from that small project. So it was a great route to impact. Next slide. So these two other projects that I'm going to talk about are focused on sort of physical health conditions among people who have severe mental illness. And you might have heard about these as well. So the first one is the UCL Partners Primrose, or the Primrose Program, which was initially led by David Osborne down in UCL. And Primrose was an evidence-based approach to delivering tailored support for people with severe mental illness and cardiovascular disease. And during the large trial of the Primrose program, they found that the intervention was effective at specifically reducing hospitalization rates among people with severe mental illness. So on the back of the large randomized controlled trial that they conducted, they moved on to this implementation program across both, I think it was London and in the north up in Bradford, which I know Dr. Gregor Russell was really leading up here. And as part of this, it was really focused on how to implement the Primrose program and this style of service delivery within primary care services up here in Bradford. And this was really useful at identifying sort of key facilitators and barriers to delivering this type of bespoke intervention in primary care settings. So the intervention itself was viewed very positively by all stakeholders, including healthcare professionals and service users. But successful implementation was dependent on several facilitators already being in place. So making sure that there was appropriate financing, that there was appropriate time for staff to deliver the intervention, and that the teams within the general practices were strong, and also that there were robust adoption processes to make sure that it was actually rolled out. And it's really important learning going forward to think about how to implement these sort of bespoke person-centered interventions for people with severe mental illness in a setting like primary care, especially with the NIHR sort of like an NHS's move towards the community as opposed to hospital-based interventions. And then the last project that I'm going to talk about is Diamonds, which is a project that I was actually involved in. So I'm quite familiar with it. And it was looking at developing and evaluating a bespoke self-management intervention for people with severe mental illness and type 2 diabetes. And this was led by Professor Najma Siddiqui. This intervention was co-designed with service users and healthcare professionals and carers, and was really intended to be as accessible and as engaging as possible to service users. So we co-designed this intensive coaching intervention. So it involved one-to-one sessions with a Diamonds coach, workbook that was co-designed and sort of written to be as accessible and engaging as possible, and also functional. And then we also did develop a digital app, which I won't say too much about because the uptake wasn't great on that. But the intervention in general was focused on participants or service users' priority. So they were really the ones leading the focus of the intervention in terms of the changes that they wanted to make to improve their health. And what we found within the trial, we haven't published the results or anything yet, but we can say that the intervention was highly acceptable. It was very engaging, and we had great uptake of this intervention throughout the large trial. Also, I think this was the largest trial to date for people with severe mental illness and type 2 diabetes. However, kind of similar to Scimitar, we are aware going forward that the landscape of healthcare service delivery, but also just diabetes treatment and care is changing. Same with cardiovascular disease as well, actually. So this intervention really demonstrated a way to get service users engaged in their physical health. But we need to be mindful again going forward that this was kind of trialed at a time when the diabetes care looks different than it does now. So in YHARC 2.0, what we really want to do is continue to focus on narrowing the mortality gap. So as I'm sure everyone is aware of, in terms of the mortality gap, people with severe mental illness die on average 15 to 20 years earlier than people without severe mental illness. And despite this investment and resources and research going into how to narrow this gap, the gap is actually widening. And I think it's important to be aware of the changes that are happening in healthcare services and delivery, some which are fantastic in terms of just overall improvements in treatment, but ensuring that they're accessible and that people with severe mental illness aren't left behind as these healthcare services change and develop. And as I'm sure you're all aware as well, people with severe mental illness are supposed to receive annual health checks through their GP to identify their health needs. So to screen for things like type 2 diabetes, or to check their HbA1c, check their BMI and their smoking status. And historically, or at least recently, the uptake of these has actually been fairly high, with these health checks incentivized through the quality outcomes framework for primary care. However, while the uptake of these are relatively high, speaking of sort of health checks in general for people with severe mental illness, the translation of that into actually accessing care that people need once an issue is detected is not reliable, and it doesn't always happen. And there seems to be a bottleneck there in terms of actually identifying an issue and then accessing care to address that issue. So in YHARC 2.0, we want to actually address that bottleneck and narrow the mortality gap by considering how healthcare services are changing, how interventions are changing, and ensure that people with severe mental illness are able to access new cutting edge treatments that are effective. So our plans going forward or to essentially look at that referral pathway issue from primary care into treatment, either in primary care or in the community, um, and improve the health of people who have severe mental illness and are managing physical health problems, or to reduce the risk of physical health problems. And the most significant change I think that has happened in relation to weight management and diabetes, type 2 diabetes specifically, recently is the introduction of GLP-1 agonists like semaglutide, which are highly effective at helping people manage their weight and manage type 2 diabetes. And there have been recent trials looking at their effectiveness among people who have severe mental illness, and they found that they are not only safe but also highly effective at helping improve diabetes outcomes and also weight management. However, there isn't really a standardized or bespoke care pathway for people who have severe mental illness in how to access these, how to deliver this sort of specific weight management or type 2 diabetes service to people with severe mental illness. And what we've learned from all of the work that we've done previously in terms of Scimitar, Primrose, and Diamonds is that people do need sort of bespoke, tailored help that addresses the reality of living with severe mental illness. So we want to, first of all, find out how this is being delivered currently to people with severe mental illness, if these services are being delivered, and then co-design a pathway that would enable people to actually access these services. And then the other big change that we've seen recently, particularly off the back of Scimitar, is a change in how the population as a whole are using nicotine. Historically, people who have severe mental illness have smoked at significantly higher rates than people without severe mental illness. And the advice tends to be that if you are smoking cigarettes, that it is better that you take up something like vaping instead to reduce your consumption of tobacco. However, what we're seeing now is younger generations in particular not starting smoking, but instead going straight to either vaping or I know there's a big surge in smokeless or smoke-free tobacco, or not tobacco, nicotine, things like snus pouches. So we want to have an understanding of how that is impacting people who have severe mental illness, because while it's better to vape than smoke, it's not better to vape than not vape for your physical health. So we want to see whether this is impacting this population and if there is a way to reduce nicotine use overall in people who have severe mental illness, to sort of like get ahead of this shifting landscape. And I think that might be that for that slide. Thank you very much, Lewis. So going forward, there are quite a few questions. We're kind of early on in the process of this work package, looking at severe mental illness and physical health. And one thing that we do want to do is embed routinely collected data in our research, but it's understanding how we can use that in an accessible way for us, to look at these referral pathways and intervention effectiveness for people with severe mental illness. A big question that has come out of past work is, once we have these effective interventions, how do we make sure that they are sustainably and consistently implemented across the board? Because that seems to be another bottleneck that we keep coming up against. And what are the key barriers between screening people, identifying that there's an issue, and then actually getting them through to an intervention that's effective? And then are there specific windows in the care pathway where this intervention should be targeting? And I think that's me. Thank you very much. Hand back to Lewis.
Sorry, I've lost my unmute button. Thank you very much, Claire. Thank you very much, Ruth, and everyone for listening. We actually have, I think, 15 minutes, Divine Nod, is that correct?
Yes.
To try and answer some questions. So I'll hang on.
Louise, I think we got some questions on the chat.
Yes.
So
Okay.
one of them is, what frameworks was used to evaluate intervention implementation in the UCL, Primrose, and Diamond studies?
Claire, is this something you know about?
I can't speak to UCL Primrose because I'm not familiar enough with that project to know what framework they used. With Diamonds, it wasn't an implementation study, so they went through from co-design to feasibility testing to the definitive trial. They haven't done any implementation work. But I do know that they use the theoretical framework of acceptability for looking at sort of the process evaluation within the randomized controlled trial.
Thank you. And then we got another question. Just wondering whether the clinical health psychology services based in acute trust is involved in this work.
At the moment, we haven't really. Whenever I say we're early days for the proposed work, we are very, very early days. I'm technically, I think Lewis was saying earlier that I'm technically not on this until September, but that's fine. With the other projects, I know that with Primrose, that was based in primary care. So there wasn't this involvement of acute trust, as far as I'm aware, whenever it came to the implementation. With Diamonds, clinical psychology services weren't involved either. We were recruiting basically anyone with either a diabetes background or a mental health background to deliver that intervention. And I can't speak to Scimitar or those other digital divide studies. I don't know, Ruth, if from your experience with the previous ARCs, if you've got anything to add from those past projects.
I don't think so. I think the digital divide stuff was just a very small feasibility trial. So, I think we just collected some light touch qualitative data, again, around acceptability and how it was experienced. So yeah, that was for the Dragon Digital Skills project.
Thanks, Ruth. There's another question. There is currently a large UK-based clinical trial looking at the use of metformin for antipsychotic-induced weight gain. Is there any trial GLP-1 analogs in the UK? If not, is this something you're looking at carrying out, or is it more about implementation of such intervention?
I know that's something that we want to do whenever we have, because we're recruiting someone into post at the moment for this SMI work package, but we want to do some scoping of the literature around GLP-1 analogs and trials. I do know that there's evidence that they are effective at managing diabetes. I don't know how many trials there are demonstrating that. So we are a bit more focused on implementation and how we can roll this out so that it's accessible to people with severe mental illness, as opposed to whether it's effective, because the evidence suggests it is effective. But I have heard of that metformin trial, and I'd be really interested to see what the outcomes are.
Thank you, Claire. I've got another one, which is a very general question. Any plans around palliative end of care for persons with SMI? I've just finished PhD in this area and I'm pal care nurse.
Hi, Marianne.
Hello, Claire.
Hiya. We know each other.
Yeah.
Yeah. For the ARC, we have nothing written in terms of like objectives, but that is, as you know, something that I'd be very interested in myself looking at down the line, because as you are aware as a palliative care nurse, and also from your PhD, the quality of palliative care and end of life care is not very good for people with severe mental illness,
Yeah.
and very difficult to access. And that is
Yeah.
not just in Northern Ireland, that is across the board. So
Yeah. Yeah.
so I'd be
No,
interested in looking into it.
I'm losing my voice at the minute, so excuse me, but now I know Claire well. And it was just, that was one of the reasons I came today, was because I finished my PhD. I'm actually retiring out of palliative care, and I want to go into mental health research in this area to try and stay, because I feel it's probably, I don't know how you feel as well, it's really, really neglected. I think even within, totally neglected within palliative care research, but probably similarly and within mental health research. If anybody knows anything, I'm just networking because I'm due to retire. I'm thinking about a feasibility study or applying for some postdocs within. I want to stay within mental health research to promote this area, because I feel that's where it needs to be. But that's all it was. It was really just to network and say hello. And I know Claire, obviously, she's been very
Yeah.
supportive.
You've also reminded me that I was meant to email you a couple of names by that.
It's okay. That's fine.
Sorry.
That's fine.
Marian, we've got also our research inclusion lead. She works as a palliative consultant. I can email you. I can introduce you to each other as well If
Yeah,
that
that would
help.
be great. That would be great. Thank you. Thanks.
Any questions? Anything else? I think that's it. This one. Oh, Emma's like talking to Marian about setting up their new YHARC. Thanks, Emma. Any questions for Louise, Claire, and Ruth? Nope. I think that's it. Any we will share the slides. Is that okay? Louise and Claire and Ruth, to everyone, and also we'll share the recordings. And I'm really sorry about my voice. It's the hay fever, guys, the season. But yeah, we will share all the recordings and all the information. And any questions, please do email us. Get in touch with us. Thank you so much, everyone, for joining us in our Lunch and Learn. Looking forward for mental health theme for this ARC 2.0 for 5 years. Thank you so much. Thank you, everyone. Bye.
Thanks.
Thank you.
Bye.